Bismillah ar-Rahman ar-Rahim. Good evening, everybody. It is another fantastic night for CardioGo Java Case Box. We did already one wave 2 months ago, and I think we had a bunch of cases which were very interesting for all, interactive. And I promise that tonight we have also a bunch of interesting cases. And on top of these cases, we have a very important topic and a very important guest, Professor Muhammad Lotfi, who gave us a very important presentation about the crossroads between guidelines and daily practice. We really have a great pleasure and a great honor to have him with us this night. Professor Lotfi, please.
Good evening, everybody. At first, it's my pleasure to join you in this very elegant, educative webinar, together with my dear friend, Professor Said Farag. I think that CardioGo now is one of the very important conferences in Egypt and in the Middle East. It's my pleasure to join you today. Today, we're going to present a case. He's a female, 26 years old, and he's a smoker and this epidemic. And this patient was living between Egypt and Saudi Arabia, and he has very bad dietary habits. He presented with epigastric pain, and he received for the epigastric pain proton pump inhibitors, but the pain was not relieved. At the fifth day, the pain was recurrent with dyspnea and the profound sweating. And he sought medical advice. He went first to a gastroenterologist, and the gastroenterologist referred him to cardiology, as for cardiology assessment, after suspecting the presence of an acute coronary syndrome because of the persisting chest pain. And the patient was even not convinced to do the ECG, but after pressure of the gastroenterologist, he went to do an ECG in the same day, and the ECG showed the raising of the ST segment in the inferior leads. The troponin was high, 4.6, CKMB mass was 44, renal function was normal, and his LDL level was 175. The echo was done and revealed ejection fraction of 50% and inferior wall hypokinesia. No doubt this patient is indicated for urgent intervention. He was loaded with aspirin 300 milligram and ticagrelor 180 milligram and transferred to a PCI-capable hospital for primary PCI. At the time of presentation to the cath lab, he had ongoing chest discomfort, and he was bradycardic but hemodynamically stable. The heart rate was around 52 beats per minute, with raising in the inferior leads, and as we said, good ejection fraction, and his blood pressure was about 90/60. The angio was done in the same day, revealed at the left system. As we can see, we have a normal left main, normal. In the LED, there is a small plaque in the mid segment of the LED with no significant stenosis and the normal RCA. And we can see here that there are some collaterals from the left system to the distal RCA, if you can see here. And this is a picture of the RCA. As we can see, we have a total occlusion of the RCA with a very big thrombus starting from near the ostium of the RCA, just after this. And here we can see here the engagement of the catheter. We have a very big thrombus occluding the RCA and with tiny zero flow to the distal bed. Usually, I don't prefer to do left ventriculography in the setting of acute MI, but in this patient, I want to be sure that the RCA territory is viable before going for intervention, because the patient was presenting with pain on and off since 5 days. So, and the troponin was positive, CKMB was positive, and I was not sure how long was the time between the onset of and the occlusion of the vessel and the presentation. So I want to be sure, despite of doing an echo in CR with a normal ejection fraction of 50% and inferior wall hypokinesia, I want to confirm the presence of viability in the RCA territory, and I did left ventriculography after coronary angiography, which is not the usual in the setting of acute MI. And we can see here that we have a good ejection fraction and the inferior wall was hypokinetic. So, Dr. Fred, what do you think in this patient? Do you go for intervention with this big thrombus, or do you prefer to defer a little bit? What's your opinion? So, Said Farag is with us. Okay, so in this case, we have a large thrombus. The patient is young, 26 years old. He's a late presentation by inferior MI, and we have a heavy thrombus burden. And we have, as regards the TIMI thrombus grade, it's a very big thrombus with total occlusion. Grade 4 thrombus presence large size, more than 2 times the vessel diameter. This is a grade 3. Type 4, grade 4 thrombus, TIMI thrombus grade. Thrombus present large size as grade 3, but with the largest dimension greater than or equal to 2 vessel diameter. And our case, we have thrombus grade 5 with total occlusion. How we did the case? In this patient, he was a late presenter. So we found that we have some of the guidelines of the European Society of Cardiology has a clear indication when to intervene in late presenter. In patient presenting between 12 and 24 hours, and possibly up to 60 hours from the symptom onset, even if pain-free and with stable hemodynamics, may still benefit from early coronary angiography and possible PCI. Patients without ongoing chest pain or inducible ischemia presenting between 3rd and 28th day with presentation with a total occlusion did not benefit from PCI. So if you have a patient presenting after 48 hours, he will not benefit. In patients presenting days after acute event with fully developed Q wave, only patients with recurrent angina, as in our case, and documented residual ischemia. Here we have documented ischemia by the presence of chest pain and proven viability in a large myocardial territory are candidates for mechanical revascularization. And this is the setting of our patients. He's still having chest pain, and we have a proven viability by both echo and left ventriculography, and we have a large myocardial territory of ischemia, and he is a candidate for mechanical revascularization. So we passed first floppy wire to the distal bed, and we started to do manual thrombus aspiration, and this was a very difficult case because every time when I enter with a thrombus aspiration catheter, it got blocked with a thrombus. I have to go out, and then to return back, it's also stuck by the big thrombus, and I have to return back after. And we did around 30 runs of thrombus aspiration. And after many thrombus aspiration, we started to have a flow in the distal bed, and we can notice here that we have we are passed our wire in an RV marginal branch, not in the proper RC. Here we can see it in this view that we passed our wire in an RV marginal branch and not in the proper lumen of the distal RC. So we did balloon dilatation. This here we can see that our wire is in RV marginal branch, and this is the distal RCA. So I took a second wire in the proper RCA, and we did balloon dilatation of the RCA, multiple balloon dilatation. And after multiple balloon dilatation and thrombus aspiration, we reached this result after about 90 minutes of work of thrombus aspiration and balloon aspiration. At this moment, I decided not to put any stent in this patient now, because if I'm going to put stents, I'm going to implant stents from the ostium up to the end of the artery in the posterolateral branch, and the incidence of no-reflow will be very high. So I preferred not to implant a stent after having restoration of the flow in the vessel, and we have a large thrombus. And we continued on aspirin, ticagrelor twice a day, unfractionated heparin, enoxaparin for 10 days, glycoprotein 2B3 inhibitors, tirofiban for 48 hours, beta blocker bisoprolol 2.5 milligram, and after the intervention, the heart rate of the patient improved, ramipril 1.25 milligram, and we gave him rosuvastatin 20 milligram once daily. After 14 days, we did the follow-up coronary angiography, and we have a TIMI-3 flow with complete resolution of the present thrombus inside the lumen of the vessel, and we have only diffused the disease, the posterolateral branch, which needs only medical treatment, and this patient was treated without stents. This is another view, and we can see here at the crux we have some disease, and we have a posterolateral branch of PDA, which were diffused the disease, but as I said previously, I prefer not to implant stent in this particular patient. In this patient, what is the level of cardiovascular risk? I think that it goes without saying that this patient is a very high risk patient. He's a smoker, dyslipidemic, and he has an acute Crohn's syndrome. And this patient is considered as a very high risk patient. What is the target LDL for this patient? The target LDL for this patient is, I think, that 170, 55, or 50% of the baseline. The target is to have an LDL less than 55 milligram per deciliter. This patient is a very high risk patient with atherosclerotic cardiovascular disease and is considered at a very high risk. And the last guidelines stated that we have to reach an LDL level of 55 milligrams per deciliter in all and more than 50% reduction of the LDL from the baseline. Which type of statin in this patient? Well, we have to give him a high intensity statin, and we give him rosuvastatin 20 milligrams, and we have to do follow-up after 6 weeks. If we reached the goal, it's okay. If not, we have to increase the dose of rosuva up to 40 milligrams. If not reached, we have to add ezetimibe, and if not, we have to use a PCSK9 inhibitor in order to reduce the LDL and to reach the level of 55. Which antiplatelets these patients are? In this patients, we according to guidelines, it's preferred to give him ticagrelor and over the use of other available antiplatelet in our country, which is clopidogrel. We don't have here prasugrel. And we all know the Plato trial with the efficacy of ticagrelor reduction, relative risk reduction of the primary endpoints of composite cardiovascular deaths, MI, and strokes in patients who received ticagrelor versus the patients who received clopidogrel. The level of was a very high level of statistical significance with a p-value less than 0.001. There were no differences in the Plato trial between the patients treated with clopidogrel or patients treated with ticagrelor as regards the major bleeding events, 11.6 in ticagrelor group and 11.2 in the clopidogrel group. And the ticagrelor versus clopidogrel in elderly patients with acute coronary syndrome sub-study from the Plato trial also shows the clinical benefit of the use of ticagrelor in elderly patients, even if we have an elderly or young patient as our who received ticagrelor. For how long to give ticagrelor? We have to give the dose of 90 milligrams twice a day for 1 year. And in these patients, because of the heavy thrombus burden, we can extend beyond 1 year and to use a 60 milligrams of ticagrelor twice a day. According to guidelines, in patients with acute coronary syndrome treated with coronary stent implantation, DAPT inhibitor on top of aspirin is recommended for 12 months unless there are contraindications such as excessive risk of bleeding. And in patients with high risk of bleeding complication, we can discontinue after 6 months. And the Kaplan-Meier curve of estimate of primary efficacy endpoint over time as regards the composite endpoint of cardiovascular death, MI, or stroke. We have a relative risk reduction of 12% in ticagrelor group after 30 days of randomization, and at 1 year we have a relative risk reduction of 20% after 1 year of follow-up in the group receiving ticagrelor, 5.2% events versus 6.6% in patients who received clopidogrel. Another important trial is the Pegasus TB 54 trial. It's a randomized, double-blind, placebo-controlled trial. It's a multinational trial to assess the prevention of thrombotic events with ticagrelor compared with placebo on a background of acetylsalicylic acid in patients with a history of MI. And in this trial, patient subjects with a history of MI 1 to 3 years prior on aspirin therapy were randomized to ticagrelor twice a day or ticagrelor 60 milligrams twice a day versus placebo. And the results shows that cardiovascular deaths, MI and stroke, 7.8% of the patients receiving 90 milligrams twice per day, and 7.8% in patients receiving ticagrelor 60 milligrams twice a day. And the TIMI measured bleeding was 2.6% in patients with ticagrelor 90% and 2.3% in patients receiving ticagrelor 60 milligrams twice a day. So in this trial, we have the cardiovascular events in patients receiving 90 milligrams of ticagrelor was 7.8. In patients receiving the 60 milligrams, it was 7.8 also, and the patients receiving placebo, the cardiovascular events was 9%. So when patients were treated after 1 year from MI, we have reduction of measured adverse events of about 2.2% absolute reduction with in patients receiving ticagrelor. So among patients with prior MI on aspirin therapy, in addition, the addition of ticagrelor was beneficial, and ticagrelor compared with placebo reduced the risk of cardiovascular death, MI, and stroke, but was associated with increased major bleeding. And the ticagrelor now is preferred to clopidogrel and prasugrel for long-term treatment if patients with low risk of bleeding, and we have to continue. We can continue on ticagrelor 60 milligrams twice a day, and this is a very safe and very protective, and you can reduce the risk of cardiovascular death, MI, and stroke. And according to the last DAPT guidelines of the European Society of Cardiology, clopidogrel and prasugrel, if patients is not eligible for treatment with ticagrelor. So if the patient is eligible to take ticagrelor, it is preferable to continue on ticagrelor 60 milligrams twice a day if there is a clinical indication to continue on ticagrelor beyond 1 year. So my take-home message that, first of all, in our country, Egypt and in the Middle East, we have a very high risk patients. And even if we use the score of the range of the risk score, which is the scores, it can underestimate the risk in patients with in our patient population because of the high mortality with cardiovascular disease in our country and in our region. In men more than 40 years and women more than 50 years, we should consider should be considered for cardiovascular risk factor screening and risk estimation for future cardiovascular fatal and non-fatal events using the score charts of European Society guidelines. And even if we use a score in our patients, it may underestimate the risk. So our patients, as we have seen, we have a patient 26 years old with a very big thrombus, and who can imagine that the patient is 26 years old will present with this ugly lesion in the outfit. As the use of high-intensity statin is recommended for very high-risk patients for life. In our patient, he has to continue on high-intensity statin forever, for life. For acute coronary syndrome patients, switching from clopidogrel to ticagrelor is recommended early after hospitalization, irrespective of the timing and loading dose of clopidogrel. There is no doubt all the guidelines of European Society of Cardiology and the American guidelines, nowadays ticagrelor is preferred over clopidogrel in the setting of acute coronary syndrome. If not available, you have to use clopidogrel. The only two clinical indications to use clopidogrel if the patient is on anticoagulation or if the patient has received lytic therapy and you are doing rescue PCR. And even if the patient did the rescue PCR, you can shift after 3 or 4 days to ticagrelor. And if the patient presented to you with an acute coronary syndrome, and even he was on a background therapy of clopidogrel, you have to shift. Why to shift? Because ticagrelor offers to the acute coronary syndrome significant reduction in mortality without any increase in major bleeding. My last take-home message is that using ticagrelor 60 milligram is recommended beyond 1 year. If you are going to continue on dual antiplatelet therapy beyond 1 year, you can use ticagrelor 60 milligram twice a day. You will have the benefit of reduction of cardiovascular composite endpoint, death, MI, and stroke, and also you have an accepted bleeding risk. Thank you so much, and I think if you have any question, we are with you.
Thank you, Professor Lotfi, for this very elegant presentation. Very important case, actually a daily practice case, and we have a lot of messages from this case, of course. I think the first important message here is how to be a wise interventionist, because sometimes most of us will be pushed on putting a stent in such an artery, and I think the sequelae will not be good because of the heavy burden of the thrombus. The second message here is how to assess the patient's risk properly in order to plan the proper management strategy, long-term management strategy of HAM, especially these patients. Of course, it seems that he has a high thrombogenicity, which needs, I think, extension of the dual antiplatelet therapy, as Professor Lotfi tell us the evidence behind this. Professor Lotfi, what do you think if there is any place in your case to start the case without doing aspiration, with doing if in my place, in your place, I will do aspiration in my. But do you think that there is any place to do at the start a small balloon dilatation to check the situation or not? This is the first question. My second question is, do you think that multiple balloon dilatations would not affect the microvascular circulation and do some sort of obstructions and no reflow? I'd like to know your opinion about the 2 points.
Okay. For your first question, you are going to start with thrombus aspiration or not? Usually what I do in patients with total occlusion, we have to start with a small balloon, and we do a very gentle balloon predilatation at the site of occlusion. And if we find that we have no flow and still we have a very big thrombus occluding the vessel, such as a thrombus grade 4 or more, we have to start with the thrombus aspiration. And we did our department in Alexandria a very good study comparing the use of thrombus aspiration in selected patients with TIMI-3 thrombus grade 3 or more, and we found that the patients who benefit from thrombus aspiration are patients presenting with a large thrombus grade 3, 4, or 5. If you have a patient presenting with a small thrombus, there is no need to complicate things and to go for thrombus aspiration. Go for balloon dilatation or even direct stenting. But if you have a heavy thrombus burden, such as our case, after gentle balloon predilatation, we found the largest thrombus, and we have to go for thrombus aspiration. So we have to test your vessel first with a small balloon. If you found that you have a big thrombus, go for thrombus aspiration first, then go for either, as we have done in our case, to be wise a little bit and not to put stents, such in our case, or to implant a stent if there is a clear clinical indication to put stent at the setting of the acute MI.
And what about the frequent balloon dilatations and the high incidence of microvascular obstructions and impairment of the distal fluid?
In our case, we have an occluded vessel. We have a thrombus starting from the ostium up to the bifurcation in the crux. So there was nothing to lose with balloon predilatation and the multiple balloon inflations. We don't have a vessel. We don't have any flow. So we tried several times balloon dilatation. We used a long non-compliant balloons in order to minimize the trauma to the vessel wall, and we don't go for at a very high pressure. We go for at a reasonable pressure, and we respect the vessel diameter in order to, if we do balloon dilatation, we avoid the dissection and also avoid trauma to the vessel wall.
Did you started the GB2B3 inhibitors immediately when you saw the angiography or after aspiration?
No, we started in the cath lab after aspiration. After restoration of the flow, and we found that there is a residual thrombus, we started it. The tirofiban inside the cath lab after restoration of the flow. And when we decided not to put a stent and to defer, we started. I gave intracoronary tirofiban.
Do you think do you think there's any rationale for that? When we saw a big thrombus burden like you presented in your case, should we start the GB2B3 inhibitors immediately or wait until the aspiration done?
In my case, I saw that I have to continue on dual antiplatelet, heparin, and 2B3 inhibitors for the first 48 hours to give a full chance of the full antithrombotic to resolve this heavy thrombus and to see after 2 weeks what's going on. And I think this strategy was successful in our case.
Yes. I think, Professor Muhammad, also another important point you give us this night, that the extension of dual antiplatelet therapy, especially in your patient, of course, he is already a high-risk patient. This is number one. Second, with high thrombogenicity. This is number two. I'd like to clarify more, how long should we go for the dual antiplatelet therapy? Especially that we have now the dose of 60 milligram for ticagrelor, which give us the facility to prolong our dual antiplatelet therapy.
According to guidelines, up to 30 months nowadays. But in some cases, if we have a high thrombotic risk, we can continue beyond 1 year, especially if we have a polyvascular patient. If the patients we have peripheral arterial disease or carotid disease, together with coronary artery disease, this patient benefit a lot from dual antiplatelet, extended dual antiplatelet for a long period. If there is other territory affection, either, as I said, polyvascular patients, carotid atherosclerosis, or intracranial, or peripheral arterial disease, and these patients are extended beyond, even for life.
Yes. Another important point also is the use of the high-intensity statin. As you mentioned in your take-home messages that we have to give a high-intensity statin for life, but I'd like you also to clarify for us the follow-up intervals we should use to confirm that the patient is on the target of LDL in order to either keep him on statin only or to shift to another non-statin therapy or even PCSK9 inhibitor.
In our patients, we did a baseline LDL, and the LDL at the baseline was 175. After 6 weeks, in this patient, the LDL was not reaching the target, and I have to double the dose of rosuvastatin to 40 milligram. And after doubling the dose of rosuva, I reached LDL of 74. When I did not reach the target after 6 weeks, after 40 milligram of rosuvastatin, twice, 2 tablets once daily at night, I added ezetimibe with rosuva, and I can reach the goal with 55 with 40 milligram of rosuvastatin and ezetimibe 10 milligram in this patient. So when to do, I think first we have to do it after 6 months. If you reach the target, it's okay. If not, double, or the dose of, if you can double, such in our case, double the dose to the maximum tolerated dose of statin. If you do not reach after 6 weeks, you have to add ezetimibe. If you do not reach, you have to add PCSK9. So the time interval is around 6 weeks.
Okay.
Till you reach the target.
Okay. I think it was really a fantastic presentation about one of our daily practice. Carried a lot of messages, how to manage the patients with high thrombus ECS and how to plan for his long-term treatment, especially that the patient had high thrombogenicity, and also he is a very high-risk patient. Again, thank you, Professor Lotfi, for such a fantastic presentation, such a fantastic case.
Thank you.
And we are really honored to have you with us this night. And we hope to join us in the coming IAPA CardioGo Case Box. Thank you, Professor Lotfi.
Thank you, Professor Said. Thank you for Astra, and thank you also for the organizing company ICOM for the perfect organization. Thank you so much. Thank you.
Thank you very much, Professor. Again, good evening, everybody. We have again a fantastic night of IAPA CardioGo Case Box, which is a joint meeting with JAG Case Reports. And we have the honor to have the chief editor with us today, and also the associate editor, and a bunch of professors who present to us a very fantastic, unusual cases for intravascular imaging. I think this is the second wave. The first wave was for the structural heart disease, and we promise to present you a very fantastic and interesting interactive waves in the coming months. This is what Julia promised me to do, and I know that she will do it. Now I think I have to leave the mic for Professor Julia, the chief editor of JAG Case Reports, to present our wave today, which is a part, of course, of the IAVA activities. So, Professor Julia, please.
Thank you so much, dear friend El Said. Good evening to everybody. From here, I'm in London, and we have, first of all, three distinguished people from the editorial board they will give lectures today on coronary pathology, but also distinguished professors from IAVA. It's a great collaboration between the two, let's say, the journal and the organization of IAVA. For us, it's a great pleasure, as always, to be here. As dear friend El Said said, we will have the third one, which will be also very exciting. And from my side, just to mention that you're always, all of you, welcome to submit your cases to JAG Case Reports. They will undergo, of course, peer review. We have every good intention, to advise people if they have a good case on how to write better. And in fact, within the next few days, we will advertise a mentoring program that will be for 6 months. And it will be a series of lectures that we will practically help people to not only to write, but also to review papers, to understand the publishing process. That's brand new. It's the first time that I'm announcing this in a meeting. So thank you so much for your support.
Thank you very much, Professor Julia. And I'd like, on behalf of Professor Ashraf Rida, till he joined us, to present the bunch of professors today. We have with us here Professor Kaplu and Professor Vidovic, Professor Hidzik, Professor Nirina Okasha in Shams University, Professor Hazem Khamis, the director of Wadi Nil Hospital, Professor Ahmed Kamel, National Heart Institute, Professor Muhammad Abdeshafi, Banha University, Professor Amr Gamal, he is from Egypt, but he's working on UK now. And I think we have also here Professor Hani Ragi, the consultant and professor of cardiology, National Heart Institute. I think we have a bunch of great professors, a bunch of great presenters, and we will leave you for a break. Then we will start immediately the cases. Please wait with us.
Okay, Bismillah ar-Rahman ar-Rahim. It's an honor and pleasure to share this meeting. And the format of the meeting will be first case presentations. I'd like to recommend for the presenter, if after putting the clinical scenario and the angio and the image, we can stop and discuss if you are the operator, what can you do? So we'll start with Professor Hedzi. He will give us a case about the spontaneous coronary artery, the role of intravascular imaging. Professor, you can start.
Dear Professor Farag, dear Professor Kamis, dear Professor Grapsa, thank you for having invited me to be a part of this great meeting. I would like to present today the topic of spontaneous coronary artery disease and the role of intravascular imaging. I would like to talk about the epidemiology and pathophysiology, the role of intracoronary imaging, and the role of management in spontaneous coronary artery dissection. I would like to do that by presenting two cases that were published in the JAC case reports. The first case is spontaneous coronary artery dissection and STEMI in a patient with anomalous LAD artery. A 39-year-old woman was brought by ambulance with chest pain and transient syncope. She has a history of generalized anxiety. The patient had been doing well until she had undertaken an exercise class during which she developed palpitations and followed by syncope on the day of presentation. On presentation in the emergency department, the patient was in distress and diaphoretic. On examination, her temperature, her blood pressure, heart rate, and respiratory were normal. The remainder of physical exam was also normal. ECG demonstrated ST elevations in leads 1, AVL, V2 through V5, and was suggestive of anterolateral STEMI. Differential diagnosis included acute coronary syndrome, arrhythmia, and stress cardiomyopathy. The patient underwent emergent cardiac catheterization through radial access, which demonstrated an isolated circumflex originating from the left coronary cusp and the dominant right coronary artery. The LAD was found to originate anomalously from the right cusp, and following a large perforator, septal perforator, was occluded. So the LAD was wired and intravascular ultrasound was performed. As you can see here in the longitudinal view, the dissection was very long, exceeding 50 millimeters. First, you can appreciate here on the panel A halo bands, which are suggestive of intramuscular course of a proximal part of LAD, and then on the panel B, you can appreciate a large intramural hematoma compressing the true lumen. So the decision was to revascularize, and the drug-eluting stents were deployed 4 millimeter distal to the dissection up to the ostium of the LAD, which restored normal TIMI free flow in the LAD. So the post-PCI echocardiography revealed depressed left ventricular fraction of 35%. The patient was discharged home on a dual antiplatelet therapy and a beta blocker. During follow-up, the symptoms resolved. The patient resumed normal physical activity. Left ventricular ejection fraction improved to 42%, and there was no evidence of fibromuscular dysplasia, collagen vascular disease, or autoimmunity. And the second case I want to present to you today is the acute de novo presentation of multi-vessel spontaneous.
Professor Herzig, can we discuss first the first case first, because we need to interrupt the cases together. Dr. Nirina Okasha, what do you think about the management of the first case from the start? Do you think this is maybe an iatrogenic dissection with the catheter, with the guiding catheter, or with the diagnostic catheter? The second, how can you recommend to have another image during the STEMI case like this, when you suspect a dissection, not just a thrombus occlusion?
The patient presented with ST segment elevation MI, so we have to. She has to have a cause for this ST segment elevation. So I don't believe that the catheter caused this dissection. I believe that it is a spontaneous dissection because of her age. She is athletic. She doesn't have any risk factor for coronary artery disease. So and it's more common in females. So I believe that this is a spontaneous coronary dissection. That's it. But because she presented acutely, I think the management of putting a stent was excellent to be done. As regards the other modality of imaging during acute MI, I think I don't know what will be done on rapid way. Maybe the OCT. I don't know. The dissection will reveal why it occurred by the OCT. Maybe we can find the cause of it. Maybe I don't know. I really don't know.
Okay. Dr. Mohammed, excuse me, Dr. Mohammed Tabl. Do you think there is tips and tricks for dealing with the spontaneous dissection during STEMI patient, wiring, types of wires, type of handling? Do you think if there is any tips and tricks to deal with spontaneous dissection in an acute coronary STEMI? Okay.
I think Dr. Mohammed should unmute, please. Mohammed Tabl, unmute.
My professor, Dr. Hazem, having a spontaneous dissection, I was surprising to having this spontaneous dissection in cath lab. I think it is a surprise or nightmare for the cardiologist. So I think rapid dealing to maintain the flow, we can have no flow or TEMI 1 or TEMI 0 flow with spontaneous dissection. So hurry up with wiring, maintain the flow in the artery, and how to seal the proximal segment with a stent. I think there is no single scenario for dealing with such cases. It is a nightmare. Rapid dealing, maintain the flow. I think I can use multiple balloon dilatation and sealing the dissection with drug-eluting stent in the proximal segment, and deal with the other complication later. I have no single scenario for myself.
Dr. Hazem, if I can add something, Dr. Hazem, please, if you can allow me. I think now we have two problems in this case. The first one is the spontaneous dissection. The second one is the anomalous origin of the LAD from the right coronary cusp. So we are facing two problems. I think the first problem is choosing a choice of the guiding catheter to engage this anomalous origin of the LAD. This is one. Actually, I had a case yesterday, anomalous origin of LCX from the right coronary artery, a patient with non-STEMI. And I was, I spent too much time just trying to engage the anomalous CX origin. So this is the first problem, how to engage with a suitable guide, a selective suitable guide inside this anomalous vessel, then choosing the wire, a non-hydrophilic wire, so that the wire will not pass in the false lumen. I think these are the tips or tricks in this case, or these are the problems we should keep in consideration in such a case.
Can I add something, Dr. Hazem, if it's okay? Can I add something?
Okay, we can postpone the third comment until the second case, please. Dr. Herzig, you can go to present your second case.
Okay, this is the case of acute de novo multivessel spontaneous coronary artery dissection. A 49-year-old woman presented to the emergency department with worsening chest pain and crescendo angina, which lasted over the prior few weeks. She had a history of hypertension and acute coronary syndrome, treated with stenting of obtuse marginal branch in 2016. On examination, the patient was hypertensive and tachycardic. Physical exam was otherwise unremarkable. Electrocardiogram was normal. Her troponin levels were slightly elevated. Her blood work, including cell count and comprehensive metabolic panel, was also unremarkable. So the work diagnosis of non-ST elevation myocardial infarction was made. But the differential diagnosis included acute coronary syndrome secondary to plaque rupture, very late stent thrombosis, embolic phenomenon to coronary arteries, or spontaneous coronary artery dissection. The patient was treated with heparin, aspirin, clopidogrel, statin, beta blocker, and IC inhibitor, and an early invasive strategy was planned. On the left-hand side, you can appreciate both the LAD and the left circumflex are both patent with normal coronary TIMI-free flows, and there was no evidence of stent thrombosis in the stent in the obtuse marginal branch. However, in the mid panel, you can appreciate the non-flow limiting dissection in the distal right coronary artery. Given the TIMI free flow and resolution of symptoms, the decision was made to treat this dissection conservatively. But on the third day of hospitalization, the patient experienced a recurrence of severe chest pain with high elevations in troponin levels, with T-wave inversions in lateral leads on electrocardiogram, and echo showed mild anterolateral wall hypokinesia. So the decision was made to go with a repeat coronary angiography, which revealed progressive spontaneous coronary artery dissection of the distal right coronary artery into the posterior descending artery and posterolateral branch with TIMI-free flow, and a new spontaneous coronary artery dissection of the septal perforator, and diagonal branch with TIMI-0 flow in the diagonal branch, as you can see, appreciate here on the sign image. So the diagonal branch was wired, and an IVUS was performed, which confirmed the dissection with an intimal flap. Here you can appreciate intimal flap as denoted by the red arrow, with a large intramural hematoma denoted here by the red arrow head. So the patient underwent 4 stents implantation, which were deployed in the diagonal artery, and it restored normal blood flow with TIMI-free flow at the end of the procedure. The patient underwent in hospital further workup and CT angiography of the head, neck, chest, abdomen, and pelvis did not reveal any evidence of fibromuscular dysplasia. The patient's symptoms resolved after the second coronary angiography and the PCI, and the patient was discharged home on day 5. In hindsight, we think that the spontaneous coronary artery dissection was misdiagnosed as atherosclerotic coronary artery disease in 2016. So we can discuss the case now, Professor Kamis.
Yes, another case. Thank you very much. Another case for spontaneous dissection, right coronary, diagonal, treated at the end with the stents. I think one of our colleague have a comment from the previous case. He can start his comment.
So my commentary, Prof. Hazem, is just for dissection, for spontaneous dissection or even for guided dissection. Although OCT could be standard diagnostic test, but we have to be very cautious injecting with using OCT if we are not 100% sure that we are in distal lumen. In this case in particular, I would prefer, although in spontaneous dissection, even as a sort of dissection, I prefer to use an IVUS instead. IVUS, you use an ultrasound. If you use an IVUS where you can identify where true lumen is, you can use OCT later on. But use an OCT upfront without being 100% certain if you are in a true or false lumen can easily actually go propagate the dissection all the way down the vessel. So in this case, in dissection, I would do as Dr. Ahmed Kamil has advised. I would use non-hydrophilic wire, and I will use IVUS first. I can use OCT later on, but to confirm if I'm true lumen, IVUS is much safer. Because I use ultrasound, I don't inject any contrast in IVUS.
Okay. Dr. Hedzik, do you think the stents were mandatory in these cases? Can we solve this spontaneous dissection with long-standing balloon inflation? Can we do that without putting metallic stents inside a dissection? Because the stent will not treat the original cause of the coronary dissection, especially the spontaneous one. What do you think?
It depends on the length of a dissection. If it's a short dissection and it gives ischemia, balloon inflation might be a good idea. But if it's a long dissection, I think stents are probably more appropriate. You are right by saying that we do not treat the condition itself. We only treat the acute ischemia or hemodynamic instability. As you can see here on the slide, spontaneous coronary artery dissection is a rather rare cause of acute coronary syndromes, accounting up to only 4% of all acute coronary syndrome cases. But when you look to acute coronary syndromes in women under 50 years of age, it accounts up to 1/3 of the population. So the condition has a high predilection toward female sex and towards younger patients. However, similar involvement is seen across all races.
Okay. Dr. Sayed Farag, do you think it is difficult to wire a spontaneous dissection? If there is any tips and tricks for wiring this dissection, because you may use multiple wires to go to the true lumen, you may have the wires inside the dissection several times. If there is any tips and tricks for the wiring of long spontaneous dissection to be dead sure you are in the true lumen?
It's a very important question, Professor Hazem. The tips and tricks during wiring of dissection or spontaneous dissection. I think first we have to use multiple views to confirm that we are in the right track. This is number one. Number two, we have to choose a hydrophobic wire and to avoid the hydrophilic wires, not to proceed through the dissection without feeling that we are in the dissection. This is another important point. And I think also the manipulation and shaping of the tip of the wire is very important. According to the course of the vessel, we have to shape and we have to be meticulous in shaping the tip of the wire because the abnormal shape or unwanted overshaping of the wire, I think, may lead to aggravation of the dissection plan. I think those important tips that I'm usually using during manipulating a dissection. I don't also know what is the other opinions on this point.
Okay. Yeah. Nireen, this is not atherosclerotic coronary artery disease. If there is any difference putting drug-eluting stents versus bare metal stents, do you think we need to put in a spontaneous dissection a drug-eluting stents without any atheroma?
I don't know if there is a study about this or not, but from our practice, usually we leave the spontaneous dissection if it is not causing obstruction of the flow. But in a setting of an acute MI, we have to open a flow, so we will have to put a stent. Bare metal stent versus drug-eluting stent, I don't believe that there is role now for the bare metal stents, especially that they're not found anymore in plenty of places. And I think the longevity just for the doesn't depend on there is a dissection or not, but the longevity of the bare metal stent in comparison to the drug-eluting stents has been studied significantly. And we all know that the drug-eluting stents has less restenosis rate, has better longevity. So I do believe that the drug-eluting stents will be the best choice, especially that it appears in the young, but those young people are going to get old. So they will have this stent, so it's better to have a drug-eluting stent than to have a bare metal stent.
Thank you very much. We can go to the next case. Professor Paulo will give us acute coronary syndrome case thrombosis in the COVID era, because we know a lot of theories about the effect of COVID on the myocardium, on the thrombosis, on the coronaries, on the pulmonary. So Dr. Paulo will give us a case, will show a case, COVID case thrombosis.
Thank you very much. So let's go with the first case. This case was published in the JAG case report by Alicia Prieto Lobato. As an introduction, we know that the advances in PCI have made coronary stent thrombosis a rare complication. The incidence is very low, is below 100% after 30 days. But the eruption of the coronavirus disease has modified the usual presentation of many diseases, including desetting the stent placement, because this disease, as you have just said, promotes a sustained prothrombotic state. So we present a case series of 4 stent thrombosis during the COVID-19 pandemic peak in a Spanish hospital. This hospital is located in the southeast of Spain, in Albacete. The authors present 4 cases. We will discuss case 1 and case 4. This is an acute thrombosis of the stent, and the case 4 is a very late thrombosis of the stent. You have all the details in the publication. You have here the reference. And also you will find in the publication all data related to other explorations. So let's go with the case. This is a 49-year-old man that presented with chest pain. This is the ECG, panel 1A. You can see that's ST elevation in leads, lateral wall leads. So at this point, the patient was referred to the cath lab, and this is the main angio. So at this point, we can discuss later, or when you want, what to do. We have a culprit lesion that is a very small intermediate ramus here, but also you have a nice marginal branch with 2 lesions, one proximal and other distally. So at this point, what to do? The operators decide to perform a balloon angioplasty in the culprit lesion. You know, here you have the final results with a very diffuse disease and very small vessel. And they also decide to treat the non-culprit vessel because they wanted to get a short-term hospital stay. So they decide to perform not only the culprit lesion, but also the non-culprit lesion. So they placed 2 drug-eluting stents, ultimate stent, 3 per 15 millimeters, overlapped from here to here. This is the final result. And in panel 1B, you can see the new ECG 30 minutes before later. And you can see this new ECG changes. You can see a marked ST segment depression in precordial leads. So the patient was recath again. And at this point, you can see that the vessel, the culprit lesion is similar of the other angio. But you can see in the circumflex artery that there are filling defects, angiographic filling defects, very provocative in the proximal part of the stent, of the proximal stent, and also in the distal part of the distal stent. So you can see here and here. So the diagnosis was acute circumflex artery stent thrombosis. So at this point, the operators decide to perform OCT imaging. You have here all the letters are the cuts of the rung, and here the rung. Basically, we can see no compromise of the proximal edge. They saw in panel V a mild proximal underexpansion of the stent with mixed thrombus, but all the length of both stents had a thrombus in the wall, and in the distal part of the distal stent, you can see there's a mild dissection here. So at this point, another point to discussion is what to do, how to treat this situation. Here you have a summary of all the case. The operators decide to treat with intracoronary tirofiban, then perform a proximal overexpansion of the stent, and then treat with aspirin, ticagrelor, and a 24 hours continuous infusion of tirofiban after the procedure. The panel 1F, you can see the final result, and the patient did well. The second case is a very late stent thrombosis. This is an 85-year...
Paulo, excuse me, Dr. Paulo.
Yes, of course. You want to discuss, of course.
A few minutes for the first case. I saw Dr. Amr Kamal. You are here? Dr. Amr?
Yes, I am with you. Hi, Dr.
Okay, how are you? You can discuss the management of this case if you are the operator. What you will do from the start?
Of course, it's an acute stent thrombosis, so you will have to manage as a case of it is presented with the ST elevation myocardial infarction. You have to go for the cath lab. I think the management that was done is more or less inappropriate for such a case. However, for the balloon of the ramus, I couldn't do it, especially in this setting of the patients. He said that after 30 minutes there should be no more chest pain, but there is marked ST depression, and he managed this stent thrombosis with angioplasty and stent implantation with proximal optimization, and that's sufficient for that case.
Okay, Professor Julia, you think the thrombus burden have impact on the decision? If you look for this angio, the thrombosis is maybe a small amount of thrombosis at the proximal part of the stent. There is no a huge thrombus burden for this case. You think this small thrombus can explain the ECG changes, the symptoms, and at the end, the management, the manner of management of this case?
So thank you very much, Professor Kamis. I'm not an interventionist, just to start from the basics. So when interventionalists see this thrombus, definitely we had an acute thrombotic case here, but we know that COVID was so thrombogenic, but also it creates such the inflammatory storm, as we called it, that it could have a component there to have such profound ECG changes. But I would like also Pablo to give us his opinion on that, because definitely, Pablo, you cathed more patients during the COVID, so your feedback would be valuable.
Paulo, you think, Paulo, the addition of NOACs, new oral anticoagulants, as we see a lot of recommendation to use anticoagulants for COVID patients, for pneumonic COVID, for the high D-dimer, high thrombogenicity. You think for this type of stent thrombosis, you may need to add NOACs for these cases?
Yeah, that's a very good point to discuss. The thing is, I'm not really sure what should we do regarding this point. I know this patient finally was discharged with anticoagulation. So I think this is empiric from the little data we have and all the reports we are publishing. But that's an option. I think if you ask 5 interventionals and 5 will say just leave it with antiplatelet therapy, and the other 5 maybe if they are more innovative they will do it. In my opinion, I think maybe for me the question also was what to do with the distal dissection, because there's an objective image of a dissection, and what to do, put a stent or not, because I don't know the trigger. The trigger maybe is the thrombogenic state of the COVID, but we have some other mechanical factors like expansion of the stent. I'm not really sure, but I don't think this is the main cause of the thrombosis. But there are also the dissection and all the thrombus all along the stent. So if I do the case, I will think what to do with this dissection. But maybe in this setting of prothrombotic state, another stent maybe would be not very good. So I don't know what you think with this point.
I think it is a difficult decision, especially in the COVID area and the thrombogenicity of the case. We may treat this distal dissection with just small balloon long-standing inflation. If I do another run of the OCT and I found there is no major dissection, no limiting flow dissection, I will treat only the non-expansion of the proximal stent. Dr. Paulo, you can start your second case, please.
Yes, the second case is an 85-year-old man that underwent PCI with an ostial lesion of the LAD a long time ago in 2005. He presented at the pandemic peak with chest pain, with a low ejection fraction, and you have these 2 ECGs. The 2A is the basal ECG, and without the chest pain, and in the 2B you can see the chest pain. You can see that in anterior wall leads there's a change of the ST anti-wave, ST segment anti-wave, and we have a slight anterior ST elevation. So this patient was referred to the cath lab, and this is the first injection. You can see that the stent in the ostial segment of the LAD is occluded. So the diagnosis was very late LAD artery stent thrombosis. This is the IBUS. You can see that the proximal, the left main is okay. We have no thrombus, we have no lesions, but then we see the correct expansion of the stent without malapposition, no significant neoatherosclerosis, but of remark, we have thrombus all in all the length of the stent. Here in B, here in C, and here maybe around the vessel. So the patient was treated with balloon angioplasty, thrombectomy, and tirofiban. This is the final result. So from both cases, the learning objectives published in the article is that COVID-19 increases both arterial and venous thrombogenicity. The SARS-CoV-2 hypercoagulable state may lead to a stent thrombosis trigger. The authors attribute to the COVID to be a trigger of the thrombosis in the presence of other mechanical and biological factors, because some of these patients had another comorbidities like chronic kidney disease that maybe can have a low degree of inflammation, that everything can contribute in the setting of the pandemic to the thrombosis. So they remarked that recommendations on antithrombotic treatment and PCI should be maintained during the COVID-19 treatment.
Thank you very much, Dr. Paulo. You increase attention about the how to manage patients with stents in the pandemic COVID. Do you think we need from the start in our patient having all the stents to decrease the incidence of very late stent thrombosis, to start again dual antiplatelet therapy for those patients, or add anticoagulants for those patients from the start before having acute coronary syndrome?
You mean out of the acute episode? Sorry, can you repeat the question?
Hazem, do you mean that you want to put them on this regimen when they have COVID, or just as a prophylaxis, so in case if they have COVID, they don't have complication?
If he had a COVID disease, documented COVID disease, it is better for our patient that have all the stents to start immediately again dual antiplatelet therapy during the COVID disease for 2 months, 3 months, or not? Nireen?
Me, myself, I do this. Actually, I do this. When I
Dr. Hazem, if you allow me, Professor Nabil Farag yesterday gave us a fantastic presentation about the use of the triple therapy, the bleeding risk, and the ischemic risk. And I think this is an issue important here in such cases, because one of the cases is 85 years old, and we are obliged to use an antithrombotic and anticoagulant because of the high thrombogenicity on COVID. I'd like to know the opinion of Professor Nabil Farag, because we had a fantastic presentation by him yesterday.
Thank you, Said. But first, I would like to ask Dr. Paulo about the mechanisms behind the two cases of stent thrombosis. Do you think the COVID-19 is the main cause of stent thrombosis in such two cases? Because in the first case, there was some mechanical factors like an edge dissection and improper deployment of a stent, and this could be the main cause of stent thrombosis in the first case. And in the second case, the stent was deployed in 2005. 2005 means this is a first generation drug-eluting stents. I don't know the type, but this could be a cipher stent, and we know this with this type of stents, we don't have the proper endothelialization of this type of stents, and this we used to see with cipher, especially cipher stent. We used to see this very, very late stent thrombosis, and this could be the main cause of such case. Definitely, COVID-19 is one of the main factors that's associated with increased hypercoagulability, and but we see this increased hypercoagulability in a patient who are in a certain stage of COVID, like, for example, they are desaturated, they are in a critical situation, and this is the stage where COVID-19 is associated with hypercoagulability. But in a patient who is asymptomatic or in a phase 1, phase 2 COVID, these usually are not associated with hypercoagulability. And I think the two cases you presented have this severe form of COVID-19. This is my question and my comment. As regard Dr. Said and use of triple therapy in such case, you know, with the era of this COVID-19, I think there is an overuse of oral anticoagulants like NOACs. But I think we have to have an justification, or we have to have something like increased a very high level of D-dimer or something like that to start the oral anticoagulants in such case. This is my comment, and this, I think, what the pulmonologists do in treating COVID-19 patients, they use the anticoagulants only in the late stage of COVID-19, or if they have an evidence of marked increase in D-dimer, at least a triple rise of this D-dimer.
Professor Hazem, I'd like to ask about the doses. If we will use the, Professor Pablo here, the doses of the anticoagulant you will use. First, you will use NOACs, warfarin, and what are the doses? Here, especially, we will give dual antiplatelet with the anticoagulant here. Professor Pablo, do you hear me?
Dr. Paulo?
Yes. I know that this the first patient was treated with NOACs, but we don't have that information. I don't know the dose and the agent that they used.
Okay.
So there is just to mention at the moment, because we saw the thrombogenicity, there is an ongoing trial that Dr. Fuster is running, the Freedom COVID trial, that will actually randomize the antithrombotic agents. He published the preliminary results at JACC, and there are 50 centers in the United States participating to this trial. So, there are undergoing studies on which dual antiplatelet and DOAC or warfarin is more effective. So we will see significant changes in mortality or readmission rates.
Okay, thank you. We can go to the last case in this session. Dr. Amr Gamal will give us a case about unhappy left main. Dr. Amr Gamal, we'll see what you mean by unhappy left main.
Can you hear me now?
Unmute your mic.
Sorry, unmute. So this is my presentation about unhappy left main stem, which is the hidden enemy. So this is a hospital. I'm sorry, just something's going wrong. Yeah. So this is a hospital where I am at the moment, Cumberland Infirmary, a lovely hospital in the north of England. So the case I had was a 40-year-old gentleman who presented with typical chest pain, with no known risk factor for coronary artery disease, no risk history of drug abuse either. So this is the ESG done by the paramedics. You can appreciate there is ST elevation from V1 to V4. This was around 6 o'clock, kind of, 6:30. So 15 minutes later, patient arrived at A&E and had an ECG. At this stage, the ECG, the ST elevation from V1 to V4 has become more pronounced. And I start to have ST elevation in inferior leads as well. So it's become a little confusing for me. So is it anterior or inferior or both? So usually I go right to the artery, but in this case, it was a bit of a spasm. And I was expecting a bit of complex scenario going ahead. So I decided to not waste too much time radial, and I switched to femoral artery approach using fluoroscopic and ultrasound guidance. Then I took a quick picture of right coronary artery, which is right, then look at the left system. And clearly we can see the culprit lesion, where it's proximal AD. There is thrombus, thrombus containing lesion in proximal AD, which could be the culprit. So I took a couple of more pictures for RA caudal spider. A couple of more cranial views as well. Just look at the lesion in different angles. Just on the side about this LAD size. So, ordinary angioplasty use cyan blue white cross. In presence of thrombus in the LAD, I decided to use an export up front. I pre-dilate the lesion in the LAD, and just before I put a stent, I decided to put another wire in the circumflex just to help me to protect the circ and to anchor the guide in place and help as a marker as well. Use a couple of more views to position my stent and, finally deployed in spider view, and I believe is a good positioning. So, and this is a picture just after stenting. Use 3.5 by 18 Zions, Sierra. I then took a couple of more pictures, and I posted the stent with 3.5 non-compliant to start with. And now I took an iliocrinial view. And you can appreciate there's a bit of dye hanging up, a hold up, in the left main stem, just in front of the guide tester. I took a close-up view with the same situation, with the same position in the left main stem, iliocrinial. Try to change the angulation a bit and take a close look at the left main stem. And again, there is still dye hanging up just in front of the guide. So this is what I felt at the stage. This is what the hell I've done. So it looks like a left main stem. Sorry.
We can stop just a few minutes.
Sure. Yeah.
دكتور نبيل فرج.
حازم.
ازيك حبيبي الأول. What do you think?
ازيك يا نبيل؟ ازيك انت؟ اخبارك ايه؟
What do you think? You think this is a guiding dissection of the left main?
There is overlap between the LAD and circumflex in this view. I'm not sure this is a dissection in the left main or in the very proximal part of the LAD, but I think this could be an approximal edge dissection from the stent. This is one explanation, or this is a proximal migration of the thrombus that at the site of stent. I think either one of them is either proximal edge dissection or a migration of the thrombus.
Okay, Dr. Muhammad Tabli, what do you think? Dissection, thrombus, nothing. What do you think?
Yeah, I think it is migration of the thrombus, as Dr. Nabil Farag said. And I have a question for Dr. Amr about, we have from the start TIM3 flow with the thrombus burden looks like very huge. And the patient, I don't know it was stable or not, but I have an opinion just to maintain medical treatment, glycoprotein 2BC inhibitor for a couple of days and doing another control angiography rather than stenting the proximal LED and have a risk for migration of the thrombus like this. I have a question for Dr. Amr about this point.
Okay, Dr. Ahmed Kamal, what do you think? Dissection or thrombus?
I think this is a dissection, maybe by the guiding tip, maybe by the proximal edge of the stent, maybe by the non-compliant balloon post-dilatation. These are the three possibilities for the dissection. And maybe, of course, it may be a thrombus migration, but in my opinion, it's a dissection.
Nereen, what do you think? Dissection, thrombus?
It can be anything, especially that we are having only one view, so it can be anything of those. It can be either dissection, either thrombus.
Okay. Dr. Paulo, I will not ask it is dissection or thrombus. What you will do? If you are the operator, you need an image, another image, IVAS, OCT, before you take a decision, or you will take a decision according to the fluoro, to the angio. What you will do?
Honestly, I won't be able to wait for the imaging, and I will stand. Yeah.
Okay.
Honestly.
Thank you.
Yeah.
So, Dr. Amr Gamal, you can continue what you did.
So I felt at this stage that if I assume it's a dissection, what has caused it, as Dr. Ahmed Kamil has suggested, could be guide-induced, could be spontaneous, could be stent age, could be balloon, could be wiring as well, could be the way I wired, might be. So if the dissection, what has caused it? Do I need to fix it now? If the dissection, of course I need to fix it now, of course, I can't leave it. Can I wait till next day? Or do I need to reassess the overall scenario? So I decided to reassess the overall scenario. To look clinically at the patient, which I believe is very important at this stage. So patient at this stage, he denied further chest pain. There was no drop in blood pressure or drop in pulse. SG was okay. ST started to come down. So at least at this stage, I'm a bit more safe to think and try to consider my options. So I decided to take further pictures, and to look at the anatomy and the lesion different views. At least I have two wires, down the LAD and down the circ. So in the worst scenario, I can do anything about it if needed. But just before I rush to do stenting or angioplasty, I need to first decide, what the lesion is composed of. So this is our opinion. Again, it's a bit suspicious. And if you look here in the caudal view, just going to the question about dissection, if you look at the caudal view, you can see that the guide is more or less just hanging outside the left main. It's not deeply diving the left main. So I decided to go again through the angiogram video from the beginning. Unfortunately, at this stage, from the beginning, I haven't taken steep angles, which I admit, which Prof. Noreen has advised. And I believe there's a reason for this, actually. So this is the first two pictures I took. So you can see on the left side, there is a lesion just before wiring. And if you can look here, there's a lot of dye staining. Sorry, forward. So there's a dye staining just in front of the guide tip. So this, at least it could be from the guide. It's not from the wire, not from the stent, not from the balloon. Still can be from the guide. And this is after wiring. Still, there's something suspicious here. So at this stage, I have 2 wires, no need to rush. So I decided to do an IVUS. At this stage, I elected to do Volcano IVUS with Eagle Eye IVUS, 20 megahertz. And the advantage of 20 megahertz this stage give you a bit of depth penetration. So you can see if there's a false lumen, this dissection, you can easily see it. And you can see on the left side of the screen, there is, a stent was a bit underexpanded and motherboard to the vessel wall. If you start from the beginning, no evidence of dissection you can see. However, you can see at 11 o'clock after stent, at the proximal edge of stent, you can see a bit of equiescent opacity here, just start to coming up here. And again, you can see it on the right side of the screen as well. Here at around 11 and 5 o'clock. You can see a bit of equiescent opacity on both sides. At least not a dissection. At least stent needs to be, better opposed to the vessel wall. And there is suspicion of a thrombus there. So what I did, I tried to bullseye the stent further with 4.5 non-compliant balloon. I give instruction to start tire 5 bolus and maintenance equation to go with. And I use an export again, just because I feel that the thrombus was on dissection. So I use an export at this stage because 6 French guide, I had to take the circ wire out. At this stage, I do OCT, just to confirm. OCT of left main, especially of distal left main, can give you a lot of information. Unfortunately, because the way the guide was sitting in, there's a lot of blood swirling, as you can see in the OCT, in the first part of the OCT image. A lot of blood swirling, which makes the diagnostic picture a bit suboptimal. However, we managed to get a lot of information out of the OCT. So I'm just waiting for the stent to come up because start OCT a bit distally. So here we start to see the stent, a lot of blood swirling. A lot of blood swirling still. At least there is no evidence of dissection so far. And you can find here, at this stage, there is a bit of a thrombus here. An element of a thrombus there as well. And if I go to the OCT from the beginning again, at least from the mid part of the screen, there's no evidence of intimal discontinuity, no evidence of dissection. At least there's evidence of thrombus. And this thrombus is partly starting, I believe it's partly starting from the LAD, couple of stent struts from the LAD and going all the way to left main. We can appreciate the thrombus is all the way despite, as I said, despite the blood swirling effect. And this is another OCT run. Again, a lot of blood swirling. So far, blood swirling, so it's not a diagnostic picture, I have to say. However, there's element of thrombus. Red thrombus, with high attenuation, with back scattering behind. And since struts don't look bad, to be honest, and a lot of, clot even behind around the IVUS, around the OCT cluster. So it was a thrombus then. It's not a dissection. And I have to say, luckily, I haven't stented it. And luckily, I didn't rush into stenting it because if it was thrombus, as Mohammed Tabl has advised, if the thrombus ends the left main and we rush into stenting it, could be catastrophic. So left main thrombus in this scenario could have originated from proximal extension of LAD thrombus or spontaneous minor plaque rupture in left main, or iatrogenic guide catheter-induced intimal damage, even just intimal damage with thrombus on top, or might be on top of wire balloons or other kit I have used in presence of inadequate heparinization, which is very unlikely because ST was more than 300. Might be because of coronary vasospasm, cocaine-induced, denied in history of cocaine, might be thromboembolic, including paradoxical embolism, as well might be hypercoagulable state. In terms of probability, I believe 1 to 3 are the most likely. And number one, proximal extension of LAD thrombus, I believe it was a big thrombus from the start, from left main going to LAD, not just confined to LAD. Any questions at this stage?
Yes, I'm Amr Kamal speaking here. Hi,
yes.
Hello.
Yes, I can hear.
Hi, I'm Amr Kamal. I agree with you that it's a proximal extension of the LAD thrombus. It's I think you choose a little bit shorter stent, so the stent squeezed out a larger thrombus into the proximal part at the edge of the stent to deploy, and it appears such a way like a dissection. But for me, it's far away from the guide, so it's either an edge dissection or a proximal extension of the LAD thrombus. And I agree with you that it's a proximal extension of LAD thrombus, and don't put a stent here. You can use, of course, 2B3A inhibitors, and you can assess with IVUS or OCT as you did. I agree with you.
Yeah. I think, I think it's not the LAD thrombus has shifted, just to be honest, because the appearance was there before we crossed. So I think it was actually a big thrombus from left main into the LAD. And I was just deceived by the LAD appearance, but because I was looking where the culprit is. But I believe it's not just the thrombus has migrated from the LAD to the left main. It was there from the start, but just I stent the LAD. This is what I believe.
So can I add?
Please.
Okay, can I add something? Thank you so much. This is a lovely case so far. This is what we were seeing a lot in the data coming up in IVUS and OCT of infarct-related arteries, that usually we see the thrombus and the total occlusion. It's usually anatomically 5 to 7 millimeters beyond the plaque. The plaque is actually 5 or 7 millimeters proximal to the total occlusion or the thrombus-containing lesion. And this is a great example of such a thing. And maybe like Amr Kamal just told us, a part of the thrombus was missed or not covered, maybe. These are all postulations, but again, another hint is always try to stent a little bit more proximal.
Yeah, and just before you go forward, I can just show you the spider view if everybody agrees. Just because I don't think the stent was a bit short. I think stent was just okay for the lesion itself. So I mean, I'm sorry, just going back, but just if you look at this lesion, this picture, sorry, the stent was just okay, more or less. So, I mean, even if there's a thrombus, accumulating left main because there's original LAD disease, I don't think I had to stent all the way to left main. I believe just stenting to just proximal LAD was already fine. Because if you can look here at the anatomy, we have trifurcation more or less. It's high OM, arising from the circ. And this means if I go all the way to left main, this means I'm going to make it primary angioplasty with thrombus burden, a trifurcation stenosis, which I feel at this stage, I tried to make it simple, just landed in the LAD, just, away from the ostium, like a couple millimeter into the LAD. I'm not sure, what other operators would have done in this case.
Amr, just I would like to mention a very small comment. When you read about the thrombus-containing lesion, there is a term called an angry thrombus.
Sure.
Do you know what we mean by an angry thrombus? That's a thrombus-containing lesions, and when you start to deal with such thrombus with aspiration or with a stent, whatever, or even a mechanical aspiration, this thrombus starts to spread and to increase in size, proximal and distal. This is what we call an angry thrombus. I think this is a case. This is a stent in the proximal LAD that extended and migrated more and more and increased in size. And this is a term exactly applied to what we saw in your case. I think this is a great example of an angry thrombus.
Yeah. Thanks, Professor.
Dr. Hisham Ammar, you are with us? Hisham?
Yes, Said.
Do you know, Hisham, that in most of the CAS labs, unfortunately, we have a lot of imaging modalities to assess the situation, as Amr did in his case. Do you think we can take a decision just angiographically in such a case?
Yes, of course, we can take a decision in ACS patients without using of imaging techniques like an IVUS or OCT, especially IVUS. IVUS, one of the tools that increase coronary thrombosis in patients with ACS. OCT have a data in ACS patients, but IVUS, one of the tools that can cause coronary thrombosis or increase the thrombotic burden of the plaque. But in this case, I consider the plaque-induced minor dissection and the thrombus laden on this dissection flap, especially in the IVUS. If you look for the IVUS Amr mentioned in the last picture, we can appreciate a plaque in the left main. A plaque in the left main could be a minor dissection, and after that, the thrombus laden has been put in this flap. So IVUS itself can increase the thrombus, especially if there's any undiscovered dissection. You can here in this picture, Amr, in last image, we can appreciate at 4 o'clock. Yes, at this point, you can appreciate something like a fissure plaque or ruptured plaque. So at this point, we can.
I don't think. I'm sorry, Dr. Amar. I disagree with this point first about the IVUS increasing thrombogenicity, because IVUS, like an OCT, as long as we go ST guided and you give heparin, should give us a lot of diagnostic information. So it's not something to to think of really unhelpful. I think IVUS actually is more helpful. I believe at focus, the lesions you are referring to as an intimal discontinuity, it's more actually of a thrombus. It's like a pedunculated mass here. If you look here at on the right side of the panel here, this is a thrombus actually. This is an equilucent mass going to the thrombus. Here I use the eagle eye IVUS, and the eagle eye IVUS, and if you look here, I can pause it and we have a look detail. So in eagle eye IVUS, we have the intima media adventitia. Intima is more of a fibrous plaque, so we're expecting the intima to be echo-bright. So I mean, if there's any discontinuity of the intima, it will show up here. Actually, the thrombus is more of an equilucent. Can you see here?
Thrombus, yes.
Yeah. So I mean, it's
at 6 o'clock.
It's not intimal discontinuity, because we can pause it and analyze frame by frame. But and to be honest, I went through it several times. It wasn't a dissection, and the clinical scenario overall didn't go with dissection, and there was not even intimal discontinuity at all.
Thank you, Amr. I know because we are about 10 minutes behind time, and I think there is a very interesting discussions. I think if you are going on, it will not end up. Thank you very much for this elegant presentations, elegant session. Professor Hedzik, spontaneous dissection, how to deal with the stenting. Professor Paplu, acute central thrombosis in the COVID era, which is not related to the mechanical complications of the stent deployment. Another fantastic cases. And also, finally, Professor Amr Gamal, a thrombus migration in the left main, how to deal with imaging. Finally, I'd like to thank you all, the panelists, the speakers, and we are now shift to another fantastic session with another 3 fantastic cases. So please wait with us. Thank you very much.
Thank you, Hussein.
Hello, this is Hani Raghi from Cairo. It gives me great pleasure to be here tonight on the CardioGo, organized by my friend Professor Sayed Farag and moderated by ICOM. to have the group from the JAC case reports, Dr. Julia Graspa and the rest of the team, is a real pleasure. And I've been enjoying the evening so far. I've just been given access to talk. We're now going to have an important presentation, which is STEMI in the time of COVID-19, and what have we learned so far. It will be presented by Dr. Mladen Vidovic, who is the Associate Editor of JAC Case Reports and a Professor of Medicine in Chicago and University of Illinois. Dr. Vidovic, please.
Well, great to be with you. This is so far terrific, and thank you for our Egyptian friends to inviting us from JAC Case Reports, and also thanks Dr. Grapsa for putting all this together. So what really was fantastic with this COVID era is that case reports is how we learned, because as this is all developing, we didn't have prospective randomized clinical trials. We had to learn with case reports. So I'm showing you two case reports that we published as we were living through this COVID era in the spring and summer of this year. And I'll show you two very atypical clinical presentations, which really challenged us how to approach these patients. So this is, believe it or not, this is actually my case. And this is one of our first COVID patients that showed up at the University of Illinois Hospital. Again, Chicago's completely deserted. There's nobody on the street, and they called me for a STEMI. I think it was like late at night. And this is what I see. So 61-year-old patient. He was of Hispanic origin. He had fever, shortness of breath for several days. He was febrile. On presentation, he was hypertensive, tachycardic, and tachypnic. So again, we think this is COVID. Again, just imagine those days, tests don't come that quickly. This is a 24, 48-hour turnaround for a COVID test. And this is the chest x-ray that the emergency room is sending me. So again, you see these diffuse fluff infiltrates. Again, none of us likes this, right? We don't have enough protection at this time. We're pretty much scrambling. So, and this is the ECG that the emergency room is sending me. So what do? You have chest pain, you have fever, you have a COVID-looking chest x-ray, and you have this Brugada-like ST elevation in the anterior leads. Again, we're learning. So the idea was, well, let's take a look. Let's cat this. Is this Brugada? Is this ST elevation? We couldn't tell, right? So again, a radial approach, and you see the right corner is pretty nice. This is really doesn't seem to be the problem. And then the left system looks great as well. Right. So again, no coronary disease, ST elevation, Brugada pattern. So we take the patient to the floor. We don't have the results back yet. And he develops this SVT. As you can see, like a very nice Brugada pattern in setting of an SVT. So not only do we have chest pain, not only do we have fever, not only do we have like fluff infiltrates, we also have SVT. This responded very well to adenosine. And then again, luckily, he did well. He doesn't get intubated. Fever gets better. And as the fever goes down, Brugada goes away. And you can see this, we have almost complete normalization of the ECG with resolution of the fever. So I'm just going to go back actually for a second. So we were actually very fortunate. We had Dr. Brugada himself write an editorial in the journal showing that this really, what this was, is a febrile Brugada. So this is really not probably a COVID-specific event. This is fever causing Brugada pattern in the ECG. Again, nothing related to STEMI, showing that we really had to change our thinking process when you approach these patients with quite complex presentations. Again, in setting of a COVID. Look at the date of March 31. So then, a second one I have to show you is by a different group, and actually they send this to us. And this is they call this a pseudo-acute myocardial infarction in a young COVID patient. So what they have is something a little bit different. The first patient was 61. So, you would think he would have a STEMI. So this is a 29-year-old who gets ARDS. He is morbidly obese. You can see BMI of greater than 40, and has 8 days of pretty high fever. He is being mechanically ventilated. So this is his initial electrocardiogram. And if you look at this, his axis is not that great. I would suspect likely due to his change in axis due to his obesity. But again, as you can see, there's really no pattern of ST elevation on the ECG. And then what they see afterwards, they actually see a clear inferior ST elevation. Right, so this is a little bit of a problem, right? You have a morbidly obese patient. He's on a ventilator. His high oxygen requirement. He's on PEEP, and you have ST elevation in 2-3 ABF. So their job was a little bit harder than mine, I have to say, is because I just went ahead and capped the patient. But again, what do you do here? Do you take a patient on PEEP and event to the cath lab? So this is what we really liked about this case report is so they, instead of just cathing, is they look at as well, troponin is okay, right? So again, that's fine. Myoglobin is normal, so that's actually pretty good sensitive test, negative predictive value. CKMB is elevated, but it actually kind of keeps down. So then they actually look at some other factors, like, how can let's bail ourselves out. Let's not cap this patient. Normal echo, normal motion abnormality, normal chamber size, no effusion. Okay, that's actually pretty good. And then what I really like about this case is they looked at the chest CT, and they had a chest CT because they were looking at the ARDS, and they found no coronary calcification. So they actually put a thinking process and said, well, if we have all this together, let's not cap the patient. Let's assume this is either COVID-like myocarditis or not a typical STEMI that you would want to cap. And then again, by making this judgment, as you can see, is this ST elevations get better. He improves clinically, and the STs go away. So clinical judgment got him out of that situation. And then to conclude, to show this is a paper from Jack, just actually summarizes these findings that I'm showing you from case reports. If you look at this, stent thrombosis significantly increased in COVID patients. And we saw this in the cases from the previous hour. Thrombotic milieu, very different pathophysiology. Multivessel thrombosis, and we've seen this in several of Cal's report, right? Lots of thrombus, bad thrombus. And then you can see this less of myocardial blush, right? So you can see this that the myocardial blush is less in COVID, likely suggesting diffuse microembolization / myocarditis and thrombus. And then again, there was a very good discussion before about how to treat those cases of stent thrombosis. You see, this D-dimer likely might help us to treat this with antithrombotics. And then the question before we had is NOAC, DOAC, warfarin, low molecular heparin or heparin. Again, just to show us. So this is an editorial we wrote, and I think this is what COVID really made us think is it's not only what you know is, but you also have to think about this. It really did challenge our thinking. And again, as we're getting into fall in the United States, we're keeping our fingers crossed. We won't get into another bind like we did in the earlier this year. But again, I think we know more now than we did 6 months ago. And again, likely thanks to rapid publication in case reports. So anyway, so thank you very much. And it was a great pleasure joining you in Egypt tonight.
Actually, I have a question. I don't know why did the axis change?
I don't know. I don't know. I was saying, I'm just going to go back here, is like, see this, whether this was ventilation, whether this was that positioning, whether this was fever, I'm not quite sure. I don't have a great explanation. And I don't think it's lead misplacement either, right? Because as you look at the P waves look pretty good. So I don't have a good explanation.
Okay.
And you see later on the axis comes back normal.
Yeah.
Professor Ayman, your comment and your Professor Ayman, you would like to comment? Professor Ayman, you hear us?
Can you hear me? I'm Hani.
Yeah, Mr. Hani.
Okay,
Yeah,
can you hear me now? Can you hear me?
Okay, yeah, we can hear.
Okay, this is very interesting because I enjoyed your presentation very much, Dr. Vidovic. The wave of COVID, we were relatively lucky in Egypt because it came later than Europe. So we had a lot of information from our colleagues, especially thanks to Twitter. We learned a lot before we started seeing cases. So from the very beginning, and then gradually when we started seeing a lot of COVID cases and the acute coronary syndromes and the acute MIs, gradually we actually in Egypt, it is routine for every single one of the acute MI patients, they will get a routine multi-slide CT of the lungs. It's become the protocol in all the hospitals where they call me, the patient is there, all right, I'm on my way, get a CT until I get there. So this serves multiple purposes. It allows the hospital to provide emergency service to the patients with acute MI, while at the same time helping to protect the physicians and the cath lab staff and protect the hospital so that they don't put them, if the patient has COVID, they don't put them with other patients and risk infecting others until they can be transferred the next day to an isolation center or an isolation ward in the same hospital. So we have also seen quite a few cases where they looked like ST elevation MI and we would cath them and they would turn out to be normal coronaries like the case you just showed. I don't want to talk a lot more than that because I know others have comments as well. Can you hear me?
Yeah, I can hear you.
Okay. Yes, okay.
Yeah, I think we all agree to that. My question, though, is when you get a young person with what looks like a STEMI, in the beginning, we were worried about protecting ourselves. But now we're dealing with all patients as COVID-positive patients. And I feel that if we perpetuate the notion that many, because this is not true, it's few, many STEMIs are going to be STEMI mimics, this might lead to people waiting for tests and for echocardiographies, which is okay if you do an immediate troponin but an immediately negative troponin with a STEMI would not stop me from taking the patient to the cath lab. And I think that what the message has to be is this can happen. So I would be very worried if this patient was given thrombolytic, but I would not be worried if this patient was taken to the cath lab, because I think the only thing that can happen is that operators and staff can get infected, which is of course something extremely important, but should be avoided at all costs. And even ordinary STEMI patients with real STEMI without COVID can be COVID-19 patients and may infect the staff. So at this point in time, we're past the stage of having to wait and do tests, I still think patients should go immediately to the case lab. Dr. Julia Graspa is actually asking if she can say something. Dr. Graspa, please go ahead.
No, I just want to mention, Professor Magdi, that we, as Mladen knows, that we received some manuscripts. The manuscripts coming from China, they were actually doing a lot of thrombolysis. Is that correct, Mladen? When we saw like geographical change, also because of their understanding of COVID-19, and they thought that it's so contagious, of course, that it is, that they did a lot of thrombolysis, while actually in the United States, they're doing more of cath. And I believe that, correct me, Mladen and the rest if I'm wrong, but the US, the paper that was published in JACC about the catheterization laboratory preparation during COVID, that they suggest practical and the right practices to cath the patient.
Yeah, I agree. I think, but this is an important point you made about thrombolytics. I think initially when we didn't know much, we thought we'll be giving thrombolytics because we thought it would be safer and better for the cath lab staff. I think that is the wrong thing to do because I think it can cause so much damage. And as you can see from these cases, you may end up giving thrombolytics for normal coronaries and cause a brain bleed and variety of damage. So I think what these cases also show, and I think I'm glad you brought that point, is that thrombolytic is really a bad idea because you can give it for the completely wrong reason and just
absolutely.
That's a great point.
Thank you. So if we have no more questions, do we want to move to the next presentation?
Prof. Ayman, can I add, here in Britain, what we do for patients with primary PCI, we treat all possible primaries as COVID.
Yeah.
And patients are screened at the A&E, go straight away to the cath lab. As operator, and me and all my colleagues, we all wear full PPE. We count the patient as COVID to prove otherwise. So actually, this doesn't delay the patient access to the cath lab. After the cath lab, patient stays in a cubicle, away from the rest of CCU patients until we get the results of COVID swab. So I believe, get the patient to cath lab is, instead of waiting for CT results, I believe might be a bit more important, in my point of view. I'm not sure what you think.
We don't wait for the CT scan results. Actually, we have somebody on call all the time, and they do read them. And actually, we've all learned to read them. It doesn't change our decision. The patient comes to the cath lab and we do them. It's just that it enhances our awareness and the hospital staff and the whole team's awareness for protection of ourselves as well as other patients. But it doesn't have an impact on whether we do the case or not.
Yeah, but what will happen if the patient suddenly arrested in the CT scanner? The patient with an MI is a bit unstable patient. The patient can arrest at any time. The patient can have a massive MI and during CT he had cardiac arrest because for some reason we haven't taken him to cath lab straight away.
Okay, that's an important point. The issue is if a patient, there's a dog barking somewhere.
Yes, I have 3 dogs.
Okay.
I can't mute. Maybe Yusri can mute me. Yeah.
Okay. The issue here is the patients are transferred from wherever. Going down at 1 or 2 o'clock in the morning, getting a CT scan really takes up maybe 5 to 10 minutes. I have never been to the hospital and had to wait because the patient is still getting a CT. Every single time, the patient is already up and out. And we've never really had this problem so far, and I hope we never will. Thank you. Can you see?
Dr. Nireen, first, before Dr. Ayman started, can you tell us your experience in the STEMI patient during the COVID era?
At the very beginning of the COVID era, during the months of March and April, when we have the heavy load of COVID patients, we used to do the CT, and if there is a suspect, they will be transferred to a hospital with a primary PCI facility, and which have the isolation facilities. But after that, we stopped doing this. We just do the CT, and when the CT tells us that the patient is a suspect, we just take our precautions of wearing the full PPEs, and then the patient, after we finish, they go to an isolation ward, especially made for the COVID patients with primary PCI. And as Ayman was saying right now, that it never takes a time to do the CT, because we have the CT machine inside the emergency room, and there is a 24/7 expert there. The patient, as soon as he is diagnosed with an MI, he is taken with his trolley to the CT machine, and then he do the CT in 10 minutes, and the result comes immediately, and they tell us he's a suspect or he is not, just for the precautions after we do the case, but it doesn't inhibit doing the cases.
Can I say a comment about this? Because
yes,
I think like you and Ayman has given an impression that this is like a local or a national protocol. I mean, I have been doing my primary PCIs, and I took 2 patients with completely normal coronaries and pseudo STEMI as well. We were wearing our spacesuits. We suspected very much that this was going to be the case because the patients did not have risk factors. But I actually never send a patient before a primary PCI to do a CT scan. I mean, if my patient is not going to have a point of care ultrasound, a POCUS, I will not send the patient to an echo lab. I mean, patients, as you well know more than I do, die while they're waiting, and I think 10 minutes I don't think any CT scan. I don't think the patient can be diverted to a CT scan, get scanned, and come back in 10 minutes. But even then, that would be too long. I mean, I would totally disagree. I haven't done a single CT scan before a primary PCI.
Hani, this is the protocol of the Ministry of Health, and this
right.
This is a strict rules of the hospitals, which are
right.
Well,
it should be changed. It's the wrong protocol.
No, I don't.
You should tell them that.
We never lost a patient when he is doing his CT, because actually we don't send a patient to the CT if he is unstable.
You're lucky. You're lucky. Yeah.
I want to add something. I just want to add a quick point.
Not like that.
I want to add a quick point. Number one, as Nareen just said, this is the protocol. I mean, I've done primary PCIs in the COVID era in multiple hospitals. Every single one of them, they require a CT before the patient is taken to the cath lab. Number two, as we all know.
So let me tell you, if the patient is COVID positive. No, my question is, if the patient is COVID positive and they have an extensive STEMI, and you do the CT and he's got ground glass all over his chest, are you not gonna do him?
Henny, that's not the point. Let me finish my point.
We used to give thrombolytic therapy in this situation.
Okay.
If he is not in a primary PCI hospital, or if we don't have an isolation ward, because of the fear of the infection of the whole staff at the cath lab, and during his transfer, and this is a problem. This is not a fight.
Dr. Hani, please, Dr. Nareen. I think because we are running of time, we have, Dr. Hani, please, you have to present Professor Ayman to present his case, please.
Okay. It gives me great pleasure to present my dear friend Ayman Abul Magd, the man who actually taught me in the 80s, for the first time in my life, how to do a PTCA, who's going to present a therapeutic dilemma of regulations versus new technology, to fly or not to fly. Ayman Abul Magd, MD, FSky.
Okay, thank you very much for the kind and generous introduction, Henny. I want to thank Professor Saeed Farag for his efforts for organizing this meeting year after year and gathering such an excellent group of panelists and speakers. My best wishes. Before I start, I just wanted to add something. In the COVID era, every single PCI, primary PCI, is delayed a little bit for the staff to be protected, and the 10 minutes have no impact on the patient's welfare. My presentation here, as you can see, is a therapeutic dilemma of regulations versus new technology. To fly or not to fly. I love the title you gave, Dr. Farag. Chose the title To Fly or Not to Fly. This is a patient who is 56-year-old male. He's an ex-smoker. He works as a commercial airline pilot. 6 years previous to this presentation, I put in 2 drug-eluting stents in his proximal LED. Since that time, he's been completely asymptomatic, fully active. Because of his work, every year they get a routine exercise treadmill test. And this time it was read as normal at 10 mats. He reached almost 10 minutes, reached a peak heart rate of 156 beats per minute. Every year they get the stress test and it's always been normal. This time they required him to have stress myocardial perfusion imaging, which was read as mild anterior ischemia. Subsequently, his work required that he get a diagnostic coronary angiogram for further assessment because they needed to determine whether they would allow him to fly or not to fly. So we took him to the cath lab. It's a radial. He has a non-dominant, small, diffusely diseased right. And then this is his left coronary. Circumflex here looks fine. The left main and the proximal LED seem fine. The stents in the LED look fine, but we notice something in the dominant circumflex. Again, the LED looks fine, but you look at the circumflex and it's quite concerning. The same lesion we saw previously, you can see it here. It's a lesion for considerable concern. LAO, again, you can see the lesion. If you'd like to see, play again here. And again, so in multiple views, we can see that the LED looks fine, nothing concerning, and the dominant circumflex has this lesion. And this is an aureocaudal. So, to stent or not to stent. Summarize the situation. This is a very high-risk, demanding profession with a huge responsibility. Number 2, he has an angiographically severe lesion in a patient with known coronary artery disease and prior stents. The work supervisors already demanded the angiogram, and the pay for the operator is not bad and could be easily and happily justified. But on the other hand, the exercise treadmill test was normal at a high workload and at a heart rate of 156 beats per minute with no symptoms or EKG changes. Number 2, the area read as mild ischemia on the myocardial perfusion imaging was not, the area as read as mild ischemia was in the distribution of the LED, not in the circumflex. 3, as we all know, stents are of added benefit only for improving symptoms, saving lives in life-threatening scenarios. But as we all know, stents do not prevent infarction. Now we know from data, from Nico Peel's data, who's the pioneer really of FFR and IFR, of FFR, from the DEFER trial, is that if you look at the event rates, when the patient has an FFR, more than 0.75. If you do a stent, you have a doubling of the event rate compared to not stenting these patients. And this is from the ESC guidelines, 2013. PCI reduces the incidence of angina, but PCI has not been demonstrated to improve survival in stable patients. And PCI may increase the short-term risk of infarction, and PCI does not lower long-term risk of infarction. Now, further in the progression of our evolution of our knowledge, FFR versus IFR, as shown in the defined flare trial. IFR is a pressure wire, which is an alternative to FFR. It has the advantage of being vasodilator free, and it has a similar power to detect ischemia. The cutoff point for FFR, as we all know, is less than 0.8 is the cutoff when we treat. For IFR, the cutoff point is less than 0.89. And when compared to FFR, it was shown to have, using these cutoff points, the cumulative event rate was similar for FFR, equal to IFR. So the key question in this patient is, what is the acceptable risk in this patient to fly as a pilot or co-pilot? Now, in aviation, the Federal Airline Aviation Association states that the current consensus risk threshold for an acceptable level of controlled risk of acute incapacitation is 100%. To ensure the incidence of a fatal air accident is no greater than 1 per 10 to the power 7 hours of flying. This is a minuscule risk, and this is known as the 1% safety rule. Now, so as we have determined, the acceptable risk is 1%. If we look here at FFR and IFR, look at the incidence of infarction. With IFR, it was 0.94. What is the incidence of death? It was 1%. So IFR would satisfy their criteria. Not only that, but it has the advantage over FFR of providing 10-fold fewer procedural symptoms and signs. It's much more comfortable to the patient, where these symptoms of dyspnea, chest pain, rhythm disturbance, hypertension, vomiting, nausea, bronchospasm, or others were present in about 30% of FFR patients related to adenosine, and IFR is much less, it's 3.1. Obviously, those symptoms are transient and short, but they are very uncomfortable to the patient. So our decision was to go ahead with IFR of the culprit. We did actually the LED first, then obviously the main issue here is the culprit, what we presumed to be the culprit. We wired, we calibrated, and I told them, usually we get 3 measurements. I told them we're going to get 5 measurements, and if one single one, only one of those 5 is below our threshold, I would stent the patient. We did it 5 times, and every single one was above 0.91. This one here is an example, was 0.93. So a full report was provided, including the angiogram and the 5 measurements of the IFR, and was submitted to the FAA with CDs, which made the decision to allow him to fly without any delay, which the following week. And he did fly happily. Why happily? Because obviously I didn't know this at the time. I was trying to make a scientific, informed, responsible decision. encompassing all the gestalt of the situation. Afterwards, I realized that the FAA testing for coronary artery disease for pilots, a heart attack or intervention procedure. So either if the patient has a heart attack or if they get a successful routine stent placement for treatment of coronary artery disease triggers a minimum of a 3 months observation period where they cannot fly. This period is extended to 6 months if the patient has left main stenting or if they get CABG. Afterwards, which they undergo repeat evaluation for FFA recertification through the special issuance authorization procedure of FAR. This, after that, they would be allowed to refly again. So if I had put in a stent, he would have been grounded without pay for 3 months. Obviously, I learned a lot afterwards by reading about it. And thank you for your attention. And I don't want to take more of your time. Any questions, please?
Ayman, are those rules new or
Sorry, I can't hear you. Nereen?
I'm asking Ayman if these rules are new rules or they have been there for years, because I believe that till the year maybe 2005 or 6, because I had a couple of patients before that time, they were dismissed from flying because of one of them because of an anterior MI, and he had a stent, and he actually his LV function was great and it was done immediately, and another one he had an elective procedure and he too was dismissed from flying. So are those new?
Yes, those are. If you look at the slide, can you see the slide?
I can see it.
Can you see my slide?
This is 2013 or?
Yes, in late 2013. Actually, this is data from 2014. And it just says here that in because he's talking about something else, but I'm just showing you that this is later than 2013. Yeah. So the case specific scenario you mentioned was probably a long time ago.
Okay. Ahmed Shawi, lovely case, Professor Ayman. It's a great case, as usual. Thank you so much. And yes, Professor Nini, yes, the changes in the FAA regulations have been there. But just a small comment, Professor Ayman, I wouldn't take the FAA now, after they're being bombarded after the 737 MAX. They've been bombarded the past 2 days for a lot. So the FAA are taking a real big beating right now. But lovely case, yes. Excellent effect. Thank you.
Thank you for your comment. I agree totally. I just learned. This is data that was new to me. I did not have this data when I was making the decision. I made the decision in the cath lab. I read about it afterwards when a physician from the Egyptair company told me about that. You did good by this doing the IFR and not putting a stent, because he would have been grounded. And I didn't know, so I wanted to read. And when I read, this is what I found out. So this is actually information that I learned much later, after the whole procedure and the decision-making process was done.
Thank you, Ayman, for the very nice case.
Ahmed, how are you? Great to see you.
Nice to see you. And more to assure you and the co-pilot is that we have just 1 year ago published a data coming out of the FLAIR trial, the defined FLAIR, and there were subgrouping to measure the safety of postponing intervention based on IFR versus FFR. And we found that it's it's much safer to defer patients based on IFR rather than on FFR. So this is again another reassuring point for the gentleman that he can fly safely if the IFR is negative. The threshold and for the events in the 1 year event for up to 5 years is very low, even in comparison to the FFR measurements.
Thank you very much. I know you were part of the initial study, so it's great to hear this from you. Very reassuring.
Actually, I was going to say that even after a bypass surgery, the pilots get grounded for 1 year. And then after this year, the FAA, to relicense them, insists that they produce both a coronary angiogram or a CT angiogram to show that everything is patent, and also a negative SPECT, and they review all the data. However, having said that, some airlines have their own rules. It doesn't have, a pilot can get licensed, but he can be fired, for instance, from a certain airline and may need to work on a private jet or something. So it's interesting. It's a great case. Thank you.
Thank you very much. I wanted to put this because this is specifically from the FAA. This is the requirements, and because it was new to me, obviously, I didn't have any of this information while I was in the cath lab trying to make an informed decision for the safety of the patient, as well as a responsible decision for his profession, which affects, which is obviously very.
Can I ask you a question, Ayman? Can I ask you a question? Yes. Is this patient a smoker?
At that point in time, he was, but afterwards he stopped.
Yeah, I think all pilots who are smokers should be fired. I really do. They expose our lives to risk. Anyway, that's my own point of view.
Well, that's a different story. I was in the cath lab and was trying to. It's a very difficult decision to make because I wanted to do the right thing. It's a good thing that somehow I got a feeling. I forgot to mention an important point is that the reason he was sent for the cath is because of the so-called ischemia on the myocardial perfusion, stress myocardial perfusion imaging, despite a normal maximal stress test. And this highlights the deficiencies or the limitations of myocardial perfusion imaging, where sometimes, as we've all seen, you get a patient with mild ischemia and we don't pay attention, especially with a maximal stress test that's normal. But in this situation, because of his unique profession, being a pilot, they had to be extra cautious. And that's why he was sent.
Thank you. Anyway, I was just told by our chairman that we have guests from Europe, and we are Middle Eastern, so we're just beginning to wake up. But we know that you people in Europe sleep early, so we don't want to keep you awake with us all night. So we're going to go straight to the last presentation, which was, thank you very much, Dr. Abdelmajid, the last presentation is by Professor Ahmed Khashaba, Professor of Cardiology in Ain Shams University, a leading Egyptian interventional cardiologist, and a user of technology in a very good way, in a very good educational way, especially of coronary physiology and imaging. And I'm also, like with the last two presentations, I'm very much looking forward to seeing the last but not least presentation of the day, which is titled Angiographic Plaque is Not the End of the Way. Professor Khashaba.
Thank you so much, my dear friend, for the nice presentation, for the nice introduction. Ayman, can you please unshare your screen so I can share mine?
I will just, when I do, okay, I lost everything. Okay, now I.
Okay.
Good.
I'm trying to make the. Okay, thank you so much for having me today for this in this very nice gathering and very strong science. I'm really happy to see my friends back again. And thanks, Said, for the nice title. He put a very nice title that angiographic plaque is not the end of the way, and actually it is not. So it is a very good title for me. And when I started to thought about the title, I thought when angiography is not really the end of the way. So I tried to figure out some scenarios where the angiography is not the end of the way. In situations where we have angio-anatomical mismatch, sometimes we have angiophysiological mismatch, and sometimes we have total angiographic blindness. And I'll try to go with you through some of these in a quick way, being the last presentation, and all you want to go to bed and have some late dinner. So if I ask you about this left main image, and want to ask you about the grading of the image, we cannot actually from this view see a lot of stenotic occlusions in this particular view. And if we move to the LAO-cranial, we start to see some like 40 to 50% stenosis in the left main. And then we will argue what to do in this patient who had this, hypertension, hyperlipidemia. He's a smoker, and he has been stented with 2 drug-eluting stents before in the LAD. But here comes the value of another tool to reassess this plaque, and I'll take you directly to the area of the left main, where this is the end of the LAD stent, and this is the proximal LAD. And as you can see here, the proximal LAD is widely patent, as you see it here in the angio. But when it comes to the left main, you see how much narrowed the distal left main is, and you start to see a huge amount of calcium, nearly like 300 or 320 degrees of calcium all around. And this what gives you this confusion in the angiography to start with. And you start to appreciate the tightness of left main, especially if you compared it to the true and healthy part of the left main. So this is one of the scenarios that makes you think that, of course, angiography is not the end of the way. And this, based on these information, we started directly with primary rotablation, both to the LAD, left main LAD and left main circumference, and ended up with stenting the left main LAD circumflex bifurcation with a 2-stent technique. Another example of this scenario is this right coronary, where you can appreciate a borderline lesion in the mid RCA, and you start again to think what I'm going to do with this lesion. And this was a part of a previous study that our center was part in, is the VERDICT pilot study, where we involved all patients with borderline coronary lesions, either in the setting of a stable or unstable angina in the non-culprit lesion, to both FFR and IVUS. And I brought you this particular case because you can see an evident angiographic anatomical mismatch. You see here like what looks like a borderline lesion, but if you look down in the right lower corner, this is the area of the minimal luminal area here. But if you actually look at the virtual histology part, you see down the stream, this is a very huge black burden with a necrotic core, something that angiography is totally blind to. So again, it is not the end of the road. And we did FFR for this patient as well. And of course, as you expect, the hyperemic FFR was 0.95, and the baseline BDPA is 0.99. So it's not strange that Dr. Ayman's case with this very tight lesion might give these numbers as well, because we are measuring a totally different thing apart from what we are seeing in the angiography. Another teasing LAD lesion, borderline in the proximal LAD, again, if you remember, if you took a notice, the MLA of all the lesions I'm showing you is is about 3.1 to 3.4 millimeters square. So all of these with an MLA around 3 or above 3, and this particular LED lesion is borderline. And here in the PA cranial, you can see that the lesion itself, or the problem with the patient, is the diagonal, which is subtotally occluded, and you can perfectly and nicely see it here in the IVUS, and you can see the plaque obliterating the ostium of the diagonal. And the FFR for this lesion is above the dichotomous cutoff value of significance, which is 0.83. So we left this for LED for medical treatment, and we just dilated the diagonal with a drug-eluting balloon. A final LED borderline lesion, but this time is hemodynamically significant, and this is just to compare with the previous one. This hyperemic FFR of that lesion, which is not very different and geographically from the previous one, is 0.73, and this mandated intervention. The second scenario that I will take you through is angiographic physiological mismatch, and I didn't find better case than the one that I'm going to show you to prove my points. This was a 50 years old married lady. She was a smoker, hyperlipidemic. In the year 2009, she had recurrent episodes of retrosternal chest pain on moderate exertion, and she had an MPI which was positive for right coronary ischemia. And she did coronary angiography at another center. That time it was reported to be normal, and you see the images, normal with anomalous origin of the RCA from the left coronary cusp. She was kept on medical treatment, but back in the year 2018, she presented with disabling severe angina with minimal exertion, and even sometimes at rest that was not relieved by sublingual nitrates. Both her ECG and echo was normal, so I sent her for CT, and the CT, as you can see here, showed very nicely the origin, the anomalous origin of the RCA sandwiched between the pulmonary and the aorta. And the issue here is to pick a technology that can reveal the mechanism and the chest pain, and if it's related to anomalous coronary origin or not, and guide you through treatment. So we tried we did the coronary angiography, and it's the same picture, anomalous origin of the RCA, no actual plaques present in the coronary tree. And if we have a very closer eye to the origin of the right coronary, you can imagine that it changes its shape in angiography, if ever. But in order to prove to you this change in shape, or to see if it is there or not, we had a pullback from the right coronary up to the ostium of the RCA, and as you can see all through the way, the circular normal picture, intra-IVUS picture without any plaques inside. But once you come closer to the origin, you can start to see the slit-like appearance of the ostium of the RCA. So, and you can see it changing through systole and diastole from the circular pattern to the slit lid pattern. In order to prove is it related to the ischemia or not, we did an hyperemic FFR, and actually it was still above the 0.8 dichotomous level. But this doesn't mimic the original pathology of the lady, where there is compression of the RCA between the aorta and the pulmonary. So we did the same test, but this time with dobutamine infusion to mimic the exercise of the lady and the dilatation of the aortic root, and this time the FFR came down to 0.7. So this proved that this pathology is the one causing her the problems, and we had to stent it, and we took the length of the stent from the CT and the diameter from the IVUS, and this is the post-stenting IVUS picture, and I'll take you directly to the ostium, and the ostium became rounded and without no compression. And this is the final angiographic picture after stenting of the ostium with some protrusion into the aorta that was shown nicely with the CT, post-procedural CT. The final case I'm going to show you is very good evidence of when we can have total angiographic blindness to what's going on. And this is a courtesy of my friend Dennis Zabalawi, and he showed us a very middle-aged young woman with a 43 years old, no previous medical history and no risk factors, and she was admitted with typical chest pain and ST modification of the ECG. Troponin was slightly elevated, and the echo showed mild apical hypokinesia. And this was her angiographic during admission, angiographic pictures during admission. If you have a look, you can only speculate something mild luminal reduction in the proximal LED, and nothing else is going on. Again, this is another view from the LAO cranial. Nothing particular, but here comes why troponin elevation, young man, young woman. And if you remember the elegant first lecture of the day today, one of the reasons, one of the causes of the acute coronary syndrome in a young female is a coronary dissection. So we have to employ some technology to exclude this pathology, and actually it was not excluded, it was proven. And if you can see here, this is a very nice example of a spontaneous coronary dissection in the proximal half of the LAD. You have here the intima, and all of this is in intramural hematoma extending to a great length, or namely the first half of the LAD. Just to show you, this is the hematoma is clearly identifiable and no evidence whatsoever for any atheroma in this lady. She was planned for another angio on day 7, but in day 4 she had ST changes, dynamic ST changes in the ECG, but the pain was not severe and it was relieved by intravenous nitrates, not like the cases presented today with acute coronary syndrome and other changes. And an urgent angiogram was planned at that time, and you can see extension and worsening of the LAD hematoma, albeit there's still TIMI3 flow and no chest pain, because chest pain was relieved by intravenous nitroglycerin. So it's a very difficult decision, but as Nareen said, most of the cases we treat with intramural hematomas, especially if there is no dissections, evident dissection flaps as seen in this case. No flaps here, it's just an intramural hematoma, still TIMI3 flow. So the decision was taken to leave as such, and with close follow-up inside the hospital. And this is the angiogram 4 months later. Everything is back to normal, and this shows you the value of detection, the cause of and the detailed anatomical features from the OCT images, not to take it from only angiography. Otherwise, this would have been stented from the ostium of the left main down to the mid-LAD. And this is OCT at 4 months, shows complete resolution of the hematoma from great parts of the LAD, only with the residual part of the hematoma. You might see it here at from like 11 to 2. This is only residual part of the hematoma. I just forgot to tell you that based on the first image of the OCT, all forms of anticoagulation have been stopped because there is no dissection flaps. It's a hematoma, so they stop every anticoagulants apart from aspirin. And this is the results after 4 months with regulation of the hematoma, and echo was normalized. Only all treatment has stopped except for aspirin and beta blockers, and a complete body CT scan showed no other aneurysms or dissections or hematomas in all the vascular territories. So my take-home message for today is that angiography is not the end of the way, as Dr. Said suggested. Yes, this is true, but frequently angiography is not enough, and we have to employ other tools to reach the right decision at the right time. Thank you so much for your listening.
Thank you, Professor Ahmed, for those elegant cases. I think, Professor Hani, if you need to unmute, and if anybody have a question or comment for Professor Khashaba. Dr. Nabil, I'd like to know your opinion. At the end of the day, you did a lot of cases, and you did a lot of cases imaging guided and non-imaging guided. What do you think after this bunch of cases imaging guided? Should we have to use imaging much more frequent than we did in Egypt?
Thank you very much, Dr. Ahmed, for this excellent presentation. Definitely. Now we are doing more complex cases. We are doing bifurcation, we are doing left main, we are doing CTO with antegrade and retrograde approach. So we are doing more and more difficult and more complex cases. Both functional assessment and anatomical assessment are very important in such cases, because as Ahmed presented sometimes and Dr. Ayman presented sometimes, you see a lesions that look like an 80%, for example, an 80%, and you do a functional assessment for such lesion, you find it is not physiologically significant, and you leave it for a medical treatment, and the prognosis definitely will be much more better than if you did a stent for such lesion. Also, imaging, either by IVUS in most of the case or by are very important, especially in intervention for left main. Sometimes it guides the procedures when we are doing a CTO intervention, either antegrade or retrograde. IVUS is very important tool in such interventions. I think we have to. I think imaging and functional assessment are underused in our country, maybe because of the financial burden and increased cost of the procedure. But we have to do our best to use these imaging technologies, either functional or anatomical assessment for our patients, because the prognosis definitely will be much more better if we use these tools.
Thank you, Professor Nabil. Again, Professor Ayman, do you think that we need to customize the imaging modalities for a subsets of cases, or we should globalize the imaging modalities more and more in our practice?
Okay. Obviously, we all would love to have imaging for every single case, IVUS and OCT. Obviously, they're extremely helpful for subsets of patients, such as complex bifurcations, heavy calcifications, left mains, and cases when you really don't know, when it's difficult to make a decision. The issue is the reality of life everywhere is that that's just not possible to be able, it's financially not feasible for every single case being done in every single hospital all over the world. Healthcare is a huge burden on the financial system of any country. But obviously, it should be there in every cath lab, should be used for selected cases when you have questions, when you have burning questions, when you have doubts. And as I said, should be routine for certain subsets of patients that have been shown to have dramatic impact on the final outcome. I have a question. Ahmed, can you hear me? Ahmed?
Yes, please go ahead. Go ahead.
Yes. I enjoyed your presentation very much. I wanted to ask about the case with the right coronary, which is being compressed. I'm wondering, what is the expected long-term outcome of a stent? Will it become compressed? What is the expected long-term outcome here? I don't know if you have data on this. Can you?
It's the compression here is not dynamic as you might face if you stented a myocardial bridge, for example. The data is not very good coming out of myocardial bridge, but here the compression is static and nobody knows actually. I tried to search for the literature and to find something like long-term data for this. But there's even no consensus on treating such patient as far as I know, and correct me if I'm wrong. But what we try to do is to select a stent with a the highest radial force in the market, and to make it as long as possible to be sandwiched between the aorta and the pulmonary along the whole interarterial course. The long term we have to see, but so far for the past 2 years, the lady is doing fine, no chest pain and nothing. So we have to wait and see.
Hopefully, she'll continue to do so. It's very possible because it's a different mechanism. It's not like that strong myocardium being compressing it.
Just I would like to say a small comment about the anomalous origin of the coronary arteries, because the orifice of the normal arteries looks like an oval shape, and the anomalous origin of any artery, it looks like slit-like. So if the right coronary or the left main is a slit-like orifice. My question for Ahmed: did you go for stenting for such right coronary because it's compressed between the pulmonary artery and the aorta, or you did it because of the shape of the orifice of the right coronary artery?
Sorry, I didn't get the question. You are asking about the length?
No. I'm asking about the. You notice usually the anomalous origin of any coronary artery, the orifice looks like a slit-like. This is what we mentioned in literature. It's not an oval shape like the normal coronary arteries. And
this happens when you have an interarterial segment, sometimes intra-arterial segment. Sometimes the anomalous origin comes out without an intra-arterial segment. But
I know.
The intra-arterial is there, so as you say, almost always there is the slit-like shape that was shown in IVUS in this case.
Excuse me, because we are about 20 minutes beyond the time. If anyone have a burning question or a burning comment, in a few seconds we can go on to finalize our meeting. Any burning question or comments? So thank you very much for this very fantastic night. It's actually give a lot of messages about the use of intracoronary imaging and how can it can change our decision as shown by the great cases presented. I'd like to thank Professor Vidovic, Professor Hedzik, and Professor Bablo for the nice presentation, and also from Egypt, Professor Ayman Abou Magd, Professor Khashaba, and Professor Amr Gamal for very fantastic presentations. All the panelists, Professor Nabil Farag, Professor Nireen Okasha, Professor Hazem Khamis, Professor Ahmed Shawqi, and the great moderation by Professor Hani Raghi. Thank you very much. Professor Ahmed Kamel also, thank you very much for your kind sharing with us this session. And I leave the mic for Professor Julia to conclude this very fantastic wave.
It was a great session. Thank you, my friend El Said, and thank you to all. To our three speakers from Jack Case Reports, to the rest of the speakers from EAVA. It was I learned a lot from all of you, and now looking forward to the third one.
Thank you very much and have a good night. And please smile for the final picture. Smile. Thank you very much. Have a nice night.